This presentation was recorded at the 12th International Conference on Rapid Response Systems and Medical Emergency Teams.
Thank you very much, Mel, and also thanks to the organisers for giving me the opportunity to talk today. Just got to see if I can... Yep. Well, I always like to set the scene of where you're going to present your data from. So we're a 400-bed hospital on the other edge of the central business district. We're associated with the University of Melbourne. We have about 50,000 admissions to the hospital a year, and we have a 19-bed ICU, and we see around 1,700 patients per year. Historically, we participated in the MERIT study, and we were randomised to the active arm, and we then elected to continue with some difficulty a MET service as well as code blue for arrests at the end of it. We call it an emergency response service because it's not just going to MET calls that's important. So we have a team, we have a database, we have very regular reviews, which I'll show you, of the data. We do reports, we've got research papers, educational programs, and our liaison nurses run deteriorating patient workshops. And in 2004, we introduced a tracheostomy review service. So it's not just going out and doing calls. There's a lot of extra things that happen around it. Our team consists of an ICU nurse, an ICU registrar, who then meets up with the medical registrar on for the day. And if it's a code blue, we bring an anaesthetist because we can't guarantee airway skills on the MET team. And we do a lot of calls outside the hospital, around the grounds and in other buildings, so we need a bed. So we often have an ED person come along to help out with those. So what about our data? We introduced a database in 2003. It's got more than 10,000 calls now, and it is linked to patient outcomes. Every week, the intensivists sit down and go through every call, and we actually dictate a summary of that into the database, so that every 3 months we send a report to the ward and to each parent unit, which has every single call with some information on it, and I'll show you one of those in a minute. And then every 6 months we do a statistical report that we present to the hospital executive and to the quality committee. And last year, an initiation of our staff, they decided to pull out the data for each individual ward and then go and do a presentation there showing them what were the trends and how we could help them. So the one on the left is our audit form. It's only part of, I think it's page 1 of 3, so like everybody else's audit forms. But this one on the right is just the type of report that is generated every 3 months and sent to the units and to the wards. Has a little bit about what's been happening up the top and then a detailed response on each of the patients. It is identified, it's just scratched out for today. Now from these reviews we've been able to identify issues, and I think this is important by reviewing it on a regular basis, but early on we found that people didn't handle oxygen well. You got a call for low saturations but there was no oxygen on the patient, or the mask was on and there was no oxygen actually running, and it took a little bit of time to sort of try and teach people that that's not what you were meant to do. So we did develop an education program, and with respiratory medicine that was rolled out through the wards. But there have been other ones over the last few years about how to manage seizures, how to manage narcosis, which for us is increasingly patients self-injecting or relatives coming into the ward and injecting narcotics, which has been very interesting, and also the management of atrial fibrillation. So over on the left is our algorithm now for seizures. We've got one about managing opioid toxicity, partly because a lot of people are on long-acting drugs and patches when they come into hospital, that you've got to be aware that naloxone has a much shorter half-life than the drug. And hopefully our new atrial fibrillation guidelines, which as you can see we're developing for a smartphone distribution. I use this slide when I talk to the interns at the beginning of the year, and the diamond on the left is a patient coming into hospital. Then they have an adverse event, something begins to happen, And originally that took time to diagnose. Then you had what people call those clinically futile cycles of intern, resident, registrar and so forth before treatment is done. And then hopefully with the introduction of the MET, the time between diagnosis or recognition and definitive treatment is shortened, and that what we hope with the Deteriorating Patient Project, the new observation charts and smart monitoring in the future, that we should actually reduce the time from onset to actually diagnosis. But I think if we're looking for smart monitoring, it's going to cost money, and trying to get that rolled out will take time. But there is plenty of stuff already in our hospitals if we knew how to make use of it. So we all generally have some blue cable or hopefully a wireless network that we can log into. There's a patient master index, and then we have modules for seeing pathology, for maybe doing cardiology appointments, a lot of finance modules. We don't have a lot of modules for clinical decision support or portals of information. I should note that I think our Children's Hospital went live with Epic on Sunday or so, which will be interesting to see how that goes. And very few of us probably have physician order entry and medication management. But throughout the hospital, a lot of information is being shot around our network without us knowing it, so that every time you get a pathology result comes out, more than likely an HL7 message is going around. And what you can actually do is actually have what we call a gateway, and you can listen to those messages. They've got standard headers so that you can pick up the ones you want. And that's how we actually get information into our clinical information system, or ISA, or what it was called CareView in the past, is that we listen to these messages. But we take it a bit further than that. We listen to other people's messages as well. On the left is my phone. That's a snapshot of the screen, which says, as soon as an ICU patient actually hits ICU and the first heart rate is recorded, I get an SMS. And if you see down the bottom, if a result comes back of a very outlying sodium result, 155 or more, I get a message. So I can actually ring in and say, are you doing something about this? But we also see who's in resus. We also keep an eye on the blood gases that are being done on patients down in ED, so that we get a heads up and maybe go down and see those patients before we actually get the call. We also send emails out, if it's not that critical, of former ICU patients coming back into hospital. It's probably good that we know about some of those long stayers, and we've done the same for people in the TB clinics and the HIV clinics. Their coordinators get messages when their patients sort of hit the hospital for any reason. You're amazed the number of people who come in under surgical units who other people don't know about. And for even less urgent things, we aggregate some of these and send reports out. And this is all automated. What we're working on at the moment is that, as many people know, that everybody who gets discharged from hospital, they get a lot of diagnoses recorded. These are administrative ones. They're generally based around ICD-10. But from those, you can actually calculate Charlson and Alex Hauser comorbidity scores, and those scores are linked to risk of hospital mortality, also to length of stay, and also to administrative costs for those patients. So what we are trying to do at the moment, we've developed the algorithm at this one, but we're trying to identify those people who are high risk. For us clinicians, it might be for mortality. For the administrators of the hospital, to get them interested, it's the high-risk length of stay patient, or the one who's going to exceed their WEAS payment. And we want to automate referrals. So for a clinical one, we want to automate the referral maybe to a physician group for a surgical patient. Just on monitoring of activity, we all probably record charts like this. This is just our activity from way back in 2003. Green are the number of MET calls, blue are the code blue calls, and probably you can see that the cardiac arrests are probably declining. They're the red ones with time. But there's a lot of work around time series analysis, and that's exactly what it is. So that this is looking at the number of cardiac arrests on our wards, again going back to 2003, And every now and again you see there are spikes, and of course the hospital goes into overload and says there are 10 cardiac arrests, the world's coming to an end. But in fact what you need to be able to do is to do some statistics on that. So put in some trend lines and show people that that's nothing too bad, because our trend line continues to decrease. The other one that people are probably getting used to, certainly with our data for ICU, are these exponentially weighted moving average charts. But basically, I don't know if I push the button. Oh, yeah. These are sort of where you would expect the mortality to be between the red lines, and where the blue line is where our hospital is tracking at the time. So you can get an idea that your system is in control with regard to that outcome, which for this case is hospital mortality. And the other one I came across recently is this known as interrupted time series analysis. So again, time series, but you're looking at the impact of an event. So back here in the 2009-10, I started to get a bit concerned that our calls, getting up to 20-25% of our calls, were on patients who had a valid not for resuscitation order. And I said, should we have to drop everything to come up and see these patients when probably the parent unit or the home unit should do that work? Give us a call, but don't make a call over the phones. And you can see what happened is that in the next little while, the actual number of the calling rate went down. That's the ratio of calls on patients with not for resuscitation orders. Unfortunately, in September 2014, a new form came in, and you're allowed to tick, oh, you're not for resuscitation, but please call the Met if you have any problems. And you can see then what happened, that statistically there was a sudden jump. This is a lag of a month, and the trend line begins to sort of go up again. But if you want to look at the impact of interventions, and this is two separate interventions, then we've got this technique to do it. So it's not just raw statistics. Let's get down to some proper analysis. So in summary, I think it's important to have a coordinated service that has a team, a review, an analysis and a reporting process. I think that you will then find opportunities to improve care by identifying trends in the calls. I think it's getting more and more important to get early warning of patient deterioration or people potentially at risk. We want to even prevent that event from occurring rather than just having to diagnose it. And finally, I think we've got good opportunity to use advanced statistics to gain insights. I'd just like to thank the people of our team who've contributed a lot to getting all the data and the analysis that you now see. Thank you very much.